in the UK, and it's great to be here. So I'm going to talk about the evaluation of type 2 diabetes, management and paradigm. And obviously, Ines has already set the scene by giving us the epidemiology of the problem with diabetes worldwide. What I'm going to talk about is actually summarized in this slide, and this is news from the American College of Cardiology. And basically, what they were highlighting is that for many years, we have pursued glycemic control as a prime management for our patients. And they, unfortunately, although some of those patients achieved the targets, a lot of them still continue to have cardiovascular disease. And more recently, we have found the newer drugs that have come out, thanks to the FDA for insisting that all the newer drugs, they have to show non-inferiority or at least superiority above and beyond what we've found from previous landmark trials as the DCCT and many other trials that have come out, including UK PDS, showing that in fact, although glycemic control is achieved in a significant number of patients, actually it does not hold the development of cardiovascular disease or the progression of cardiovascular disease. And since these trials have come out, and I'll quickly go through them, some of those you already know very well, and some of those will be covered during the symposium elsewhere. But since then, we've now got rich evidence on how we can target our patients in order to address the problems that they have with cardiovascular disease. And with these trials, it's come as a call for the diabetes and cardiovascular disease navigation for the paradigm shift that the American Diabetes Association and the EADS in conjunction have come up with statements, consistent statements as to how we manage our patients to achieve these goals. I just wanted to show you this global report on diabetes that came out in 2006 from the WHO, and you can see the prevalence of diabetes in most of the regions in the world, ranging from 3 to 6% in 1980, and then by 2014, the prevalence had actually gone up to nearly 14% in some regions. And if you look at the numbers of patients, and these are staggering numbers, going from 108 million in 1980, and then going up to 422 in 2014. But there is good news. If you look at the actual all-cause mortality by country amongst people with diabetes, it's from 1988 to 2015, and this is data published by the WHO. And you can see that in some very high prevalent countries, the actual reduction has been very steep. So if you look at Finland, at the top there, you can see the reduction over a period of time was significant. And even in those countries where the prevalence was actually quite low, like Sweden at the bottom, you can see that in fact, they've also seen a reduction in all-cause mortality. And all-cause mortality tells us that intervention is actually quite powerful, and we have to look at the statistic to show prevalence. So these are this is one of the trials at the beginning that we talked about, the diabetes control and complication trial from 1983 to 1993. And you can see there actually the major impact on this study by trying to achieve a medium HbA1c of 7% was pretty much a microvascular disease reduction risk compared to the standard care when the average HbA1c was 9%. Not much impact on macrovascular disease. And then, because of these trials, and the UK BDS in type 2 diabetes, came these large studies, the landmark studies. They are called the Advanced and VATT, which, the idea was to achieve near normal glycemic control, HbA1c between 6 and 6.5%, and you can see the duration of diabetes in these people with these, in this study they were recruiting was between 5 and 15 years. And you can see microvascular disease reduction was significant, and only in our cord cardiovascular disease reduction was also significant. But in fact, that was the price we paid, that in fact there was a higher incidence of mortality in the intervention. And in fact, you recall that our cord was actually halted during 2008 on the advice of the Data and Monitoring Ethics Group because of the intervention group showed a higher mortality rate. UK PDS, again, study over 10 years intensive treatment for new onset type 2 diabetes. Complication rate reduction was seen, again with microvascular disease was very significant, and perhaps myocardial infarction as well. But once the trial was studied, was stopped, then they followed up the patients over a period of 20 years, and you can see there was a legacy reduction in risk factor, again affecting pretty much microvascular disease and not very much macrovascular disease. So pretty good results there. But then if you dig deeper into some of the subgroups across populations that we look after, and this is a subject near to my heart, which is end-stage kidney disease. As you know, diabetes is the leading cause of end-stage kidney disease. And you can see this, again, published by WHO, that in fact, the prevalence of end-stage kidney disease due to diabetes has actually increased in most countries, Mexico being right at the top of the league, and then you can see in Russia, for some reason there, they've got the prevalence or incidence of end-stage disease lower than most of the other countries, which are in between. So there is another approach that obviously requires for us to take to stop this progression to end-stage kidney disease. So, summarize what I've said so far. So the paradigm for glucose control in type 2 diabetes has been based on historical and landmark studies demonstrating the unquestionable microvascular benefit. Better glycemic control, of course, improves survival and prevents cardiovascular events, but can be at the expense of problems with mortality, perhaps related to hypoglycemia. And over the past decades, then the FDA has insisted that the randomized placebo-controlled cardiovascular outcome trials testing glucose-lowering agents should demonstrate benefit effects on mortality and cardiovascular events. And this has led way to those trials giving us a different direction in the paradigm of control of diabetes. So 16 trials have come out, and some of those have completed using SGLT2 inhibitors, SGLT1 RAs, and DPP4 inhibitors. So out of these 16, we've recruited around about 7,000 to 17,000 patients in each trial, age around 60, medium 60 years old, and duration of diabetes between 3 and 15 years. And half of those patients were on insulin, and eventually all of them had cardiovascular disease or risk factor or multiple risk factors for cardiovascular disease and hypertension. So just to quickly run through these trials, basically the idea was to look at the 3-point MACE, and you can see if we take the DPP to start with, then actually the benefit was not inferior to the old studies that I've already referred to. But for a surrogate marker, which is hospitalization for heart failure, and that showed that the DPP4 were slightly more superior to the agents. So no problem there to use the DPP4 inhibitors. And if you look at the GLP-1 RAAs, and again, these are studies, LEADER, using solalapine. Can't see this properly. If I can turn around a bit. So LEADER here, you can see showing benefit with glutide, and you can see here Sustain 6, again, same thing, Harmony, obligatide. I don't think you probably cannot see these at the back. Then you've got Rewind and Pioneer semi-glutide. Oh my goodness, so they'll come up a little bit different. It's very clear on the screen here. If you look at the other outcomes of these studies, so cardiovascular mortality, myocardial infarction, stroke, and all-cause mortality, again you can see there was a significant reduction in hazard ratio in these parameters. Then you look at the trials with SGLT2 inhibitors. There's empagliflozin, gliflozin, and then liraglutide in the DECLARE group. Again, you can see significant improvement in events in the cardiovascular diseases in the intervention arm compared to placebo in all these trials as shown in this slide. And most impressively was the one where they used empagliflozin and showing a very significant reduction in cardiovascular disease, and the number needed to treat required was only 39 in that trial. And then this one came out, which is gliflozin for the renal outcomes in type 2 diabetes and nephropathy. And again, this was published in June 2019. Very impressively, so around about 4,000 patients followed up over a period of 42 months. And you can see there again, hazard ratio for major cardiovascular events, death, myocardial infarction and stroke, significant reduction in the intervention group compared to the placebo. And in the actual summary here, you can see the primary outcome for end-stage kidney disease, doubling of creatinine, renal and CV deaths was very significant in that intervention group, and then the secondary renal outcomes are also like here. But we have to wait for the all-cause mortality to be formally assessed properly. So if we take all that into perspective, we can see here that if it's compared to the other landmark trials for cholesterol reduction over 4 years, you need 100 patients to treat 100 to produce an outcome, one outcome, and antihypertensive for 5 years, you need 125, and aspirin 333, and if you compare that to the newer drugs, gliflozin for 3 years, 39 patients, and liraglutide for 3 years, again, 98 patients. So, great news. Of course, came this consensus statement from the ADA and AASD that there is now, given all these trials, these 16 trials, and more to come out again in the future, there's a call for paradigm shift for patient-centered care. And of course, the financial market, we're excited about it, but most importantly, our patients are smiling that the doctors have got extra tools to treat this condition, and so did their spouse and their families. So they're now in a better position to contain this disease. And I won't spend too much time on this, but these are the algorithm that I've published more recently, showing that in those patients without drug treatment with type 2 diabetes who have high risk of cardiovascular risk, target organ damage, or multiple risk factors, if they don't have these factors, then they can go on metformin. Otherwise, the first-line treatment should be SGLT2 inhibitors, GLP-1 inhibitors, monotherapy, and then before you go to other second-line agents, which again, you can choose from the long list that has been published. And that's based on these newer trials that have been published. And if a patient is already metformin, if they haven't got risk factors or cardiovascular disease, then they can stay on metformin as long as the HbA1c is on target. Or if not, if they have multiple organ damage or risk factors, then it should also go onto the SGLT2 or the GLP-1 inhibitors. So it's time really to engage and educate our patients, empower them so they also are familiar with why there's a selection of drugs for them, and that actually diabetes, type 2 diabetes and type 1 diabetes should be individualized care. So this is just a very quick discussion on what actually did the patient understand about type 2 diabetes and heart disease. And I'm not sure whether you can see that. It's been published in the Association Advance in Therapeutics this year. So this is a survey of people with diabetes and those without diabetes. And you can see that in fact only half of these people were familiar with that diabetes can cause heart disease or any cardiovascular disease. And I can't read that now. But a good proportion of these patients did not have knowledge about their condition and how much can be done for them to reduce progression or more complication of their condition. So if I go back to the old slide to sum up again, so in the old landmark trials, the UK PDS, DCCT alluded to, there was focus on glycemic control as the main line of management of our patients with diabetes. But that only managed to address microvascular disease and very little impact on macrovascular disease, and particularly death from the complications. And since the FDA insisted that these large companies give us some more evidence on the outcome with cardiovascular disease as emphasis for management of these patients, we've now got a huge amount of information on how we address our patients in clinical practice. Thank you very much, Chair.